Welcome back, everyone. We're going to talk now with the second half of Section 7, Abdominal Issues, and we're going to talk about gastric and intestinal disorders. I am on page 565 in the book, and I encourage you to look on page 566, flip a page over, and this is a very good visual of their iceberg of GERD, talking about non-pharmacological, pharmacological, mind, body, lifestyle modifications, etc. So I encourage you to look at that for some of these GI issues. We're first going to talk about GERD, or gastroesophageal reflux disease, and that's where stomach or duodenal content goes up into the esophagus. It can occur at any age, but some research indicates that it increases with age and then decreases after the age of 69. There are several substances or medications that can decrease the sphincter pressure at the base of the esophagus and therefore can also irritate gastric mucosa. And the book classifies these on page 567 into two categories, being food substances, which include alcohol, caffeinated beverages, chocolate, citrus fruits, minty things, tomato-based products, and non-food substances such as anticholinergic drugs, beta blockers, calcium channel blockers, Valium, estrogens, progesterones, nicotines, and theophylline. So those are all important substances to be aware of if you have a patient that's presenting with GERD symptoms. The typical patient presents with heartburn that can range from mild to severe. They may have a sour taste in their mouth in the morning. They may have complain of belching, coughing, hoarseness. They may complain of substernal or retrosternal chest pain. On physical exam, the patient with GERD may look very normal, and their only sign may be that they are positive for occult blood or on a rectal exam, and this could be from the irritated epithelium of the esophagus. Management of GERD is to quickly reduce or eliminate symptoms. You're trying to prevent symptoms that are associated with food or exercise and prevent any complications of esophageal stricture, ulcers, or Barrett's esophagitis, any pulmonary aspiration, or any esophageal hemorrhage. The American College of Gastroenterology recommends lifestyle modifications that include weight loss, elevating the head of the bed 6 to 8 inches, and avoiding meals 2 to 3 hours before bedtime, avoiding certain foods that may trigger the reflux, and that can be individualized per person, but often the things that we had talked about from previous page, the substances that reduce lower esophageal pressures, such as chocolate, alcohol, caffeine, acidic foods, spicy foods. And the College of Gastroenterology recommends an 8-week trial of PPIs to help reduce acid production. There is a list of drugs on page 570 that are used with GERD, and they're classified according to indication, with mild intermittent symptoms, moderate symptoms, and then refractory GI disease. So I encourage you to look at those. Next on this slide is peptic ulcer disease, and that's where an ulcerated area has developed in the mucosa that's larger than 5 millimeters in diameter. Peptic ulcer disease includes both gastric ulcers and duodenal ulcers. And usually the initial damage to the mucosa is caused by H. pylori or medications such as NSAIDs. One of the hallmark signs of peptic ulcer disease is that complaint of burning or gnawing sensation, or having pain in the epigastric area, which is often relieved by foods or antacids. As we mentioned, H. pylori gastritis is involved in 90 to 95% of both duodenal and gastric ulcers that are not associated with NSAIDs, and the H. pylori infection increases with age. The mode of transmission for H. pylori is unknown, But we know that in response to H. pylori, the stomach produces more gastrin, which in turn leads to an increase in the amount of acids released by the parietal cells. And then this excessive acid and pepsin on the stomach lining erodes and leads to the development of ulcers. So there's 4 tests that you can use to detect H. pylori. One is a fecal antigen assay. Second is a urea breath test. The third is a biopsy with histological examination of the tissue. And fourth is serological antibody testing. The main goal of management for patients with peptic ulcer disease is to help relieve the pain, heal the ulcer, and prevent any reoccurrences or complications. Medications are the first line of treatment for peptic ulcer disease, but there's several non-pharmacological measures that are essential as medications, and that includes smoking cessation. Common medications that are used in peptic ulcer disease are found on page 573, and they are broken into first-line therapy, and those are for peptic ulcer disease that is non-H. pylori related, and then ulcer disease that is associated with H. pylori. So be sure and look at those. It's important to make sure that H. pylori has been eradicated, and that needs to be confirmed 4 weeks after completion of therapy. And patients with non-H. pylori associated peptic ulcer disease, follow-up is only necessary if symptoms reoccur. Next, we're going to talk about hemorrhoids, which is a mass of dilated or tortuous veins that represent prolapsed submucosal tissue. These can be classified as either internal or external, depending on their location, and the cause is primarily straining during trying to have bowel movement, which can further complicate constipation if someone sits for an extended period of time, if they're pregnant, if there's infection. On page 574 in table 40, there's a classification of internal hemorrhoids, and it breaks it down into degrees, first, second, third, or fourth. Be sure and review those. With internal hemorrhoids, the most often are present with rectal bleeding, and this can be described as bright red streaks on the toilet paper when you're questioning your patient about wiping. Initial treatment is symptomatic, and it's focused on providing pain relief with oral analgesia and sitz baths. If hemorrhoids don't improve on their own with this and decreased straining and modifications in toilet habits, patients may be encouraged to add some bulk-forming laxatives to their diet and to increase their daily fiber intake if they are not up to 25 to 35 grams to help form more regular stool. If the patient suffers from itching, they are encouraged to focus on anal hygiene. This would include sitz baths, witch hazel, and applications of hydrocortisone topically to help with the itch. And if external hemorrhoids continue to be painful or bothersome despite treatment, then they would be referred to surgery for excision. Next, let's talk about abdominal hernias. This is a protrusion of the peritoneal lined sac through some deficit or weakened area in the abdominal wall. It's important to also take into consideration when you're thinking about hernias that there has to be sufficient pressure in the abdominal cavity to force tissue out through that defect in the abdominal wall. Hernias can be multifactorial, and it's important to find out what that cause could be. There are several different types of hernias. There's the indirect inguinal hernia, which results with tissue coming through the internal inguinal ring, which in men extends to the length of the spermatic cord. There's direct inguinal hernias, and that comes out through the transversus abdominis and internal oblique muscles. And as we mentioned, environmental factors that increase abdominal pressure can enhance the chance of herniation in these type of hernias. You can have femoral hernias, epigastric hernias, umbilical hernias, and incisional hernias. With these patients, it's important to get a good history and physical and pay attention, special attention to the GI, GU, respiratory systems to see if there's any clues on what might be increasing the abdominal pressure. All male patients who present with an abdominal hernia, regardless of their age, should have a prostate exam to determine if there's any obstructive process inhibiting the flow of urine, which could increase intra-abdominal pressure. All patients need to be checked for ascites. And those patients who have COPD are at an increased risk of hernias because of the increased abdominal pressure associated with coughing. Patients may not actively realize that they have a hernia, and it may be found as an incidental finding on an exam. But when a hernia is detected, it's important that the patient be referred to a surgeon for further evaluation. Next, let's talk about irritable bowel syndrome. This is considered a functional disorder of the GI tract seen by abdominal pain or discomfort and a change in bowel habits. It has been traditionally thought of affecting women more than men, 3 to 1, but there's been some recent epidemiological studies that suggest that men and women are affected equally, but men are underdiagnosed based on the current IBS diagnostic tool. And that tool for diagnosing irritable bowel syndrome is on page 580, so be sure and review that. Patients that present with IBS, typically their symptoms fall into two categories. Those with abdominal pain and altered bowel habits that can consist of both diarrhea and constipation, and those with painless diarrhea. Most patients describe abdominal pain that starts over the colon area, with the left lower quadrant being the most affected. The pain can be sharp and burning, and it can also have cramping or a diffuse dull ache. And on your physical exam, it's usually normal except for some tenderness in above the colon, usually in the lower left quadrant or over the umbilicus or epigastric areas. IBS is diagnosed based on your history and physical exam, and is seen with increase in bowel symptoms with an onset of pain, relief of pain with defecation, heightened sensation of bowel activity, or a sense of incomplete defecation. Management includes that, as we talked about, that initial step of making the initial diagnosis and then identifying the symptoms and the patterns for each individual patient. And then based on those symptoms, therapy is going to be based on those symptoms to include diet, education, and medication and supportive interventions. There is no proven treatment for IBS, and therapy is based on symptomatic relief. And it's been found that diets high in fiber are beneficial regardless of what the predominant bowel habit is. So encouraging your patients to have increased fiber in their diet will only help. Next, let's talk about celiac disease, which is known as a gluten-sensitive autoimmune disorder that affects the small intestines, villus epithelium in individuals with genetic predisposition and exposure to cereal protein gluten found in wheat, rye, and barley. Many patients that present could be symptomatic. They also may complain of diarrhea, weight loss, dyspepsia, and gas. When you have a patient that you're concerned about having a celiac disease, serological testing for IgA antibodies should be done. This is not an expensive test and is highly sensitive and highly specific. If you have patients that are waiting for the testing or only have mild symptoms, having the patient try a gluten-free diet and evaluating their symptom of improvement can be beneficial. With these patients, it's also important to consider other nutritional deficiencies due to malabsorption, such as your iron deficiencies, folate, vitamin B12, calcium, and vitamin D, because these are all vitamins that are absorbed by the gut as well. Treatment for celiac disease is a strict gluten-free diet, and a referral to a dietitian or nutritionist may help with that. Next, let's talk about bowel obstruction, and that's any condition that inhibits the normal flow of chyme through the intestinal lumen, and it can be partial or involve or complete and can involve any segment of the large or small bowel. Generally, these patients present with a sudden onset of abdominal pain, a colicky abdominal pain that's accompanied by nausea and vomiting. The pain can be intermittent and will correspond to the peristaltic waves going through the abdomen. On your physical exam, it should include careful inspection for any abdominal scars or the presence of hernias. You're wanting to observe for dehydration, including a poor skin turgor, dry mucous membranes, or any other form of dehydration, including tachycardia. Physical exam may include a distended abdomen, particularly over the transverse and descending colon, with the presence of boroborygmy. Remember, that's the gurgling of the GI. There typically is no abdominal tenderness or guarding unless there are areas of ischemic bowel or associated small bowel obstruction with the concerns of perforation. Diagnosis of a small bowel obstruction is usually made by flat and upright abdominal films that reveal ladder-like distensions of the small bowel. Lab tests that you may do includes a CBC and chemistries. If you have a patient that has a suspected obstruction, they should be hospitalized and immediately referred to surgery. Most of these patients will require placement of an NG tube to decompress the gut and help with nausea, vomiting, and then offer rehydration. Next, we're going to talk about diverticular disease, and this is the term used to describe inflammatory changes within the diverticular mucosa of the intestine, which we know as diverticulitis, as well as the diverticulosis, the asymptomatic, uninflamed outpouchings noted. Sorry about that. Patients with diverticulosis may present with pain in the left lower quadrant of the abdomen, and they say that this pain may be worse after eating, and this may result in distension of the colon, and the pain is sometimes relieved with bowel movements or passing gas. When the diverticula becomes inflamed, there are usually signs and symptoms of infection, and you can have fever, chills, tachycardia. Initial lab testing may show mild to moderate elevation in the white count. Abdominal films should be obtained on all patients who you have concerns for diverticulitis, especially if they're concerns for perforation or peritonitis. The management of diverticulitis includes early detection and treatment, and when these things occur, prognosis is good. Often an incidental finding of an uncomplicated diverticulosis requires no intervention and can be managed with high fiber diet or daily fiber supplements with psyllium. The American GI Association suggests that antibiotics should not be routinely used because acute diverticulitis is more of an inflammatory process than an infectious one, as well as concerns for overuse of antibiotics. When antibiotics are needed, amoxicillin and potassium clavulanate are one of choice, along with Flagyl. So be sure and review those antibiotic options on page 588. Next, let's talk about inflammatory bowel disease. and it's the term used to describe chronic immunological diseases that manifest in intestinal inflammation, and the two most common include ulcerative colitis and Crohn's disease. Both UC and CD are inflammatory bowel disorders, and they share similar characteristics and causes, but are uniquely different, although the same pharmacological agents are used for both. In ulcerative colitis involves the mucosal surface of the colon, which results in erosions and bleeding and friability of the tissue. It's most often seen in the rectosigmoid area, but can involve the entire colon, but not the small bowel. Crohn's disease is characterized by segmental or patchy transmural inflammation of the bowel wall involving any portion of the GI tract from the mouth to the anus. There's a great table on page 590 that does a comparison of ulcerative colitis and Crohn's disease. I encourage you to look at that. It talks about history, age at when it presents, blood testing that can be done, common symptoms, and good information on being able to differentiate the differences in those conditions. With these patients, subjectively, there are mild forms of ulcerative colitis that commonly report 4 or fewer loose bowel movements per day, associated with abdominal cramps that are relieved when they go to the bathroom, and usually there are no associated systemic symptoms. The most common presenting symptoms for Crohn's disease are abdominal cramping, tenderness, loss of appetite, weight loss, gas, right lower quadrant pain, and or a mass, and fever. With both sets of these patients on physical exam, you may palpate tenderness in the left lower quadrant or across the entire abdomen. The patient may have guarding or abdominal distension. A digital exam should be performed to assess for any anal or perianal inflammation, any blood, or any rectal tenderness. Initial therapy for these conditions would depend on the severity of the presenting symptoms and must be individualized. In UC, initial treatment includes nutritional counseling. Patients need to avoid caffeine, raw fruits and vegetables, or other foods high in fiber. This condition is often successfully treated with a topical mesalamine, and there's a list of medications that are used in inflammatory bowel disease found on page 594, and it talks about each individual medication, its indications, and then any adverse reaction and prescribing considerations. So be sure and review that. With Crohn's disease, there are similar medication used as with UC. Glucocorticosteroids are what is deemed as the initial treatment are initially used when treatment fails and for patients that may have moderate to severe disease. There's no cure for Crohn's disease, and treatment is aimed at suppressing the inflammatory response and helping relieve the symptoms associated with it and prevent complications. We're going to talk briefly about colorectal cancer, and the majority of cases are both curable and preventable if detected early. Signs and symptoms of patients with colorectal cancer vary depending on the tumor size and the location. The cancer is often found incidentally during abdominal surgery or during a screening sigmoidoscopy. Patients may present with melena or bright red bleeding, have changes in bowel habits, changes in the caliber of the stool, but abdominal pain is a rare presenting symptom. Physical exam may reveal a mass in the abdomen or an enlarged liver, which would be suggestive of metastatic disease. Laboratory-wise, a CBC is needed to assess for iron deficiency or anemia of blood loss. There is a tumor marker called a CEA that is not sensitive or specific enough, but is used with monitoring the patient's response to therapy. Colonoscopies are needed to diagnose colon cancer with almost 100% accuracy. On page 601 are the colon cancer screening guidelines by the American College of Gastroenterology, so I want you to be sure and look at that. The first step in treatment of colon cancer is the staging, but at this point you're also making a referral to an oncologist and they're already with GI, and so treatment and the next steps will be determined by others. Follow-up is important after treatment to prevent reoccurrence, and so scheduled colon surveillance is required. I try to limit these videos to 25 minutes, but we have a couple more slides and we're going to try to push through. Let's talk next about gallbladder and pancreatic disorders, and the first one we're going to talk about is cholecystitis, which is the acute inflammation of the gallbladder, and it results usually from having a stone in the ductwork causing inflammation. These patients can present with complaints of intractable pain, indigestion, nausea, and vomiting after consuming a meal high in fat. Objectively, they can have pain over the right upper quadrant that is severe and often has involuntary guarding of the abdominal muscle over the right side. One test that you would do to assess this would be Murphy's sign. During an initial presentation of cholecystitis, you might see an elevation of the white count up to 15,000. You may see that liver function tests are elevated. You would order abdominal x-rays that may show gallstones or may show enlarged gallbladder or air within the biliary system. The gold standard for diagnosis is an abdominal ultrasound. Treatment of cholecystitis depending on many variables, depending on age, symptoms, past medical history, number of gallstones involved. There can be surgical and non-surgical options, but most oftentimes treatment is required with surgical intervention. Next, we're going to talk about pancreatitis. An acute pancreatitis is defined as an acute inflammation of the pancreas and any surrounding tissues that has been caused by the release of pancreatic enzymes, and these enzymes cause almost a chemical burn to the tissue in the retroperitoneal area, and this leads to toxicity systemically. There are several different causes for pancreatitis, and you can find those on page 606. When the patient presents, they may have a deep epigastric pain that persists for hours or days and may radiate straight through to their back. The pain can be described as intense and often doesn't respond to large doses of parenteral narcotics. It's aggravated by any vigorous activity, coughing, or by lying. It's aggravated by any oral intake. These patients appear acutely ill with intractable nausea or vomiting. They may experience sweating, weakness, and anxiety. The patient may report a history of ingestion of alcohol or a big meal prior to the symptoms presenting. On physical exam, there's severe abdominal tenderness, particularly over the epigastric area. To help make the diagnosis of pancreatitis, you're going to be checking in the presence of abdominal pain, you're going to be checking serum amylase and lipase levels, and elevation in these are consistent with pancreatitis. The gold standard for diagnosis is an elevated serum amylase level up to 3 times the normal value. However, in about a third of the patients, especially associated with alcoholic pancreatitis, the serum amylase levels are normal. Your white blood cell may be elevated from 12 to 20,000. Patients who have acute pancreatitis and no obvious causes should have an ultrasound to detect possible causes such as cholelithiasis or any cancer. There is a criteria, Ranson's criteria for assessing the severity of pancreatitis, and you can find that on page 608. Treatment in acute pancreatitis is aimed at stopping or decreasing the inflammation, preventing further complications, and managing symptoms. Treatment includes maintaining fluid status with parenteral fluids to prevent hypovolemia and hypotension. The patient is not allowed anything by mouth, and an NG tube may be considered if there's persistent nausea and vomiting or concerns for an ileus. With these patients, there's going to be daily labs checking calcium, magnesium, glucose, electrolytes, and other liver function tests, including a CBC. And you're going to want to correct abnormalities that are seen. These patients are referred to GI for management. With chronic pancreatitis, it's more of a slow, progressive inflammatory process that causes irreversible fibrosis of the pancreas. And often this chronic relapsing pancreatitis can be seen with binge drinking. These patients present with symptoms of intractable abdominal pain, weight loss, diarrhea, but they also may have mild dyspepsia, nausea, and vomiting. Abdominal pain is in the epigastric area or up in the left upper quadrant and may radiate to the back, and it may be classified as dull and constant. These patients may have weight loss, and diabetes is present in approximately 50% of these. These patients may also have steatorrhea, which is that fatty stool that develops after the pancreas is not able to secrete digestive enzymes anymore. It can be foul-smelling fatty stool. As we mentioned earlier, the major cause of chronic pancreatitis is alcohol abuse, and so abstinence is imperative. With these patients, malabsorption is an issue, and so they need to have a low-fat diet and also be on oral pancreatic enzyme supplements. And those are administered 20 to 30 minutes before meals and snacks. These patients also can have endocrine insufficiencies, and that needs to be controlled with insulin, but these patients also have deficiencies in glucagon secretion, so it's a balance of trying to figure out both, and they per the book, they can have normal, you try to maintain their glucoses between 200 and 250, and that's an acceptable range and would not require treatment. But of course, these are going to be patients that are managed by endocrinology. Also, a nutritionist would be helpful in managing their protein-calorie imbalance and be helpful to help with food suggestions to help maintain weight. All right, I think I forgot to move through on the slide for chronic pancreatitis, so that's it there. And next we're going to talk about, I believe this is our last section, cirrhosis and liver failure. So cirrhosis is the injury to the cells of the hepatocellular injury involving the entire liver, resulting in fibrosis, nodular regeneration, and restructuring of the hepatic architecture. It's considered permanent and irreversible, and these fibrotic changes can occur within the liver parenchyma and cause disruption and compression of the vascular, biliary, and lymphatic vessels, and can lead to liver failure. There are numerous causes of cirrhosis of the liver, and you can see that on page 613. Clinically, cirrhosis is often found as an incidental finding and is revealed either by an asymptomatically enlarged liver or an elevation of liver enzymes. These patients may complain of weakness, anorexia, weight loss, and fatigue. Malnutrition is evident. As the cirrhosis advances, patients may present with upper GI bleeding from esophageal varices, which is the result of portal hypertension. On initial exam, these patients may reveal an enlarged firm liver in the left upper lobe that is palpable below the right, let me rephrase that. Initial exam may reveal an enlarged firm liver edge, the left lobe of the liver that is palpable below the right costal margin. Cirrhosis may show as spider nevi in the body. You can see these on the anterior chest wall. There can be pectoral alopecia. There can be generalized muscle wasting, parotid gland enlargement, hair loss, testicular atrophy. These patients can have jaundice sclera, skin and mucous membranes that develop in the later stages of cirrhosis. They can have itching, the pruritus, that is nonspecific but is often presenting symptoms in several forms of cirrhosis and can develop as a result of the bile salts accumulating under the skin. Ascites may be seen as a direct result of portal hypertension, and it's a consequence of increased portal vein pressure. You can also have splenomegalia due to the splenic vein congestion. And then esophageal varices may be noted. They're caused by the portal hypertension, but they may be discovered if bleeding is seen with hematemesis, hematochezia, or melena. In many patients in early stage cirrhosis, lab tests are normal. However, elevated liver enzymes may be the only indication of liver disease. When trying to assess the liver and for any ascites or any nodules, an ultrasound is the test of choice. If there is alcohol-induced liver disease, then abstinence is the most effective treatment. And then if there's irreversible chronic liver disease, liver transplants are often the next step. And these would all be patients that are managed by GI. On page 618, there's a great box that has different complications associated with alcohol-induced liver disease, portal hypertension, variceal hemorrhage, ascites, hepatic encephalopathy. I encourage you to look at that. And then the last thing that is not mentioned here on the slides, but it's on the last pages of your book that you may see in practice, especially the first one, is hemochromatosis and Wilson's disease. These are two treatable inherited metabolic causes of cirrhosis. Early diagnosis is key to prevent the damage that can be done by these iron stores. Liver biopsy is what would give a definitive diagnosis per the book. And so what this is you are pulling the excess iron out of the body so it doesn't deposit in places that it shouldn't be. This is managed with CBC wanting to know what the hematocrit is and what the ferritin is, and you try to keep these patients' ferritin levels less than 50. Wilson's disease is another inherited disease, and its goal is to prevent the development of neurological or hepatic damage. The treatment includes both dietary and medicinal components. You want to limit the intake of copper, which is found in legumes, animal organs, and shellfish. And then there's the administration of a medication called Depin, which induces urinary excretion of chelated copper. And lastly, as we've talked about with most of these conditions, any patient that you have that has advanced liver disease should be referred to a hepatologist or a gastroenterologist that can help make the diagnosis, treat the disease, and manage the complications, and you may partner with them on that. Alright, so that's the end of this video. I'm sorry it ran so long. If you have any questions, please feel free to let me know. Thank you.